Thank you, Rashni. Hello and welcome everyone. Thank you for choosing to join us today. We know your time is valuable. I'm Brenda Lammy, Vice President of Professional Leadership Development at the College, and welcome you. To begin, we respectfully acknowledge that we are broadcasting today from the traditional unceded territory of the Algonquin Anishinaabe Nation. We are also pleased to be joined today by people from coast to coast to coast who, like us, live, work, and play on lands that are inhabited by Indigenous, Métis, and Inuit peoples. We invite all attendees to reflect on the territories from which you are participating as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. We recognize Indigenous, Métis, and Inuit intergenerational and traditional cultures of knowledge sharing, understanding we have a lot to learn, and hope that it is in that spirit that you join us today. We are pleased to have partnered with Vocera to bring you today's webinar, Nurse Wellbeing and the Impact of Cognitive Load, a timely and important topic that I'm looking forward to hearing more about. Today's speakers include Dr. Nancy Sears, from the editorial board of the Healthcare Management Forum, the peer-reviewed journal of the college. Over the course of her career, Dr. Sears has been responsible for the planning and delivery of home care services to a mixed urban and rural population in Ontario, and for healthcare services in a long-term care facility. She has led the planning and development of healthcare services for a population of over 500,000 people, again in Ontario, and was the conceptual architect of the Seniors Managing Independent Living Easily, the SMILE, I love that, program, a provincially funded community services program in southeastern Ontario that was credited by the Local Health Integration Network as reducing admissions into long-term care facilities. So welcome, Dr. Sears. And also Dr. Rhonda Collins, Chief Nursing Officer at Vocera. As Chief Nursing Officer, Dr. Collins works closely with nurses, physicians, and IT professionals and other hospital leaders around the world to improve the lives of patients, families, and care teams by simplifying workflows and improving clinical communication. A nurse for more than 30 years, Dr. Collins has received several accolades for her work, and in 2019, she was named a fellow by the American Academy of Nursing. It's my pleasure to now turn the presentation over to Dr. Collins.
Thank you, Brenda, and thank you everyone for taking time out of your very busy days to talk about this topic. It is, as Brenda has said, a very timely topic and an urgent topic that I think healthcare leaders need to come together to address. Nursing has always been a very, it's always been a very difficult profession and one that is busy, it's unpredictable. It can lead nurses down paths of what they didn't expect during their day. But during the coronavirus pandemic, healthcare workers in general have faced a lot of challenges that cause added stress, emotional exhaustion, and cognitive overload. One of the things that we have noticed across the world as we have worked in multiple locations is that just the added need of PPE has created a cognitive burden or a remembrance burden. As we know that donning and doffing the PPE is a place where most healthcare workers are exposed to any contagion, and many hospitals have created doffing teams in the United States just because we're trying to reduce that exposure and that cognitive burden of memory. The added addition of not allowing family members to visit has added to stress. Also included in that, of course, the mental health issues have been exacerbated by the isolation. It has been a rolling issue, one issue after another, that is all added to the problem that we face with cognitive load or cognitive burden. So each May, I write a CNO report on a timely topic for the nurse leaders working across the world to really consider something that may lead to further discussion or an issue that we can address. And the first time I wrote on the topic of cognitive burden was in 2018. And it was such a well-received topic that I started getting lots of questions of, can you take this to the next level? Then I started working with some other nurse executives who work in informatics, chief nursing informatics officers. And their feedback to me was, we have to be talking about this. We're trying to use technology to really minimize the burden that nurses carry in the patient care arena. But as it turns out, we're adding to it in ways that we did not anticipate. And so as we continue to talk about it, as I began to explore and study what cognitive burden really is, it became clear to me that it is a principle and a discipline that actually started in education. The research and study on it was done by psychologists to understand why individuals, 20 or 30 individuals can sit in a classroom. They can all hear the same information presented in the same way with the exact same notes available. And yet you will have a certain percentage that will not pass the class. You'll have a certain percentage that will excel in the class. And then you'll have a certain percentage that will retain part of what they hear. So as you look at cognitive burden and you think, now what caused that to happen? What causes that to happen? Some of you listening to me today, all of you are going to take the information and internalize it in a different way. You're going to be able to manage the information. You will hear it in a certain way. Some of you will walk away and not be able to retain any of it because your cognitive load today may be very high. So when we look at the healthcare environment, when we look at what nurses have to do, and I'm going to speak specifically to nurses because that's really where the presentation is geared to, but you can apply it to any healthcare professional at any level, from the paramedics and transfer folks all the way through to, exclusive subspecialist surgeons. Everyone works in this arena, as do leaders like you who are managing the hospitals. The pandemic has really exacerbated or highlighted the importance of paying attention to issues like cognitive burden. It's a workplace hazard, and it is something that adds to the mental, emotional, and physical distress of those caring for patients. Every day, because of cognitive overload, mistakes are made. All of us can think back perhaps when we've made a mistake. If we could just go back and have 5 seconds or 30 seconds to redo, that we would do it in a very different way. For nurses, medication errors, not giving information in a timely manner. This photograph really highlights, how a nurse manages the multiple tasks that they have to deal with every day. Where is transport? Did the patient get transferred? Where are the labs for another patient? And then there's always the personal of, I have to get cash for the babysitter before I can pick up my child. All of those things. And it's cognitive burden has to do with how we retain and parse information. So let's just talk about and really define cognitive load. It's the total amount of mental activity imposed on your working memory in one instance. It's that moment of trying to get out the door and thinking I've packed my bag with X, Y, and Z, and then getting to the airport and realize that you forgot ABC. It's because there's no more space in your ability, your cognition capabilities. Short-term memory actually lasts only about 15 to 60 seconds. Sometimes the literature tells us it can be as short as 8 seconds. Not all cognitive load is bad. It can help you to define, remain sharp. If you know there's a day where you're working with not a lot of other stuff in your mind, you know that feeling of being crystal clear and being able to retain information and move quickly from task to task. Not every day is like that, and it's for a very specific reason. It's because problems arise when the load exceeds the capacity of the person trying to process the information. So let's talk about the 8 core cognitive capacities. We all have them. All of us are gifted with this. Some of us do much better than others at, say, multitasking. My husband is a dismal multitasker. I pride myself. He says I'm not, but I think I am. I work multiple issues all the time at once. So let's just go through a quick definition. The first one is our ability to sustain attention, or that's the ability to stay focused on a task for an extended period of time. The other is our response inhibition. our ability to shut out distractions and stay focused on that task. There is literature that says that if you are concentrating on a task, say you're writing a paper or you're working on a specific project, if someone interrupts you, it can take you up to 18 minutes to get back to where you were. And that has to do with your cognitive load at that moment in time, what you're able to shed and what you're able to concentrate on at any given time. If you look at speed of information processing, that's how quickly someone can process information or process written notes to be able to reference those notes. If you look at cognitive flexibility and control, it's the ability to quickly switch between thoughts. I'll give you an example. As a nurse, you know, you have more than one patient and you're trying to take care of these patients. You know, frequently you will have more than one physician attending a single patient. And just think of trying to communicate with the physicians that are caring for just one of your, say, 4 patients. You have to know their preferences. You have to know how they want to be contacted, whether it's by pager or by phone or through an answering service or overhead page. A nurse has to commit all of this to memory on every single patient. They have to be able to know what task they have to use or what method they have to use to accommodate preferences and the environment or the culture in which they are working. So I want to look at probably the ones that are most indicative of error or mistake or can lead to error or mistake are the final 4, which is multiple simultaneous attention, the ability to switch attention between activities or multitask. And I didn't define cognitive flexibility, which is the ability to switch between thoughts. But let's talk about multiple simultaneous attention, the ability to switch attention between activities or to multitask. Working memory is the capacity to remember and use relevant information. And then category formation is the ability to organize information into conceptual categories. You know, how do you bucket this information? How does this lab value, how does it apply to the current status of my patient with a GI bleed? Those are the things that the nurse has to constantly reform and move information from one bucket to another, then put it back in the first bucket based on new information that they receive. And then pattern recognition is the ability to perceive patterns and anticipate what's going to happen next. So another thing that is really important to understand about cognitive burden is actually what we bring to that. And there's 3 definitions of the context of cognitive load. We just talked about the 8 core cognitive capacities. And let's talk about the 3 contexts in which it resides. There's an intrinsic cognitive load, which is what you bring every day with you. It is the load or the burden of having a special needs child or having an elderly parent that you care for, having financial worries, or, you know, in a situation like they're in with people being displaced from their homes. It is that constant load. I call it the backpack that you can't take off. It's what goes with you everywhere you go. And some days that backpack is heavier than other days. It is just, that is a fact. And we all work with it and we all learn to accommodate it and function within that. Then there's extrinsic cognitive load, or that's what the environment delivers. If you can imagine, I've got my backpack on of my my responsibilities in my life that go with me everywhere. Now I show up at work and I have a full load of patients. And not only that, my patients are infectious and I have to prepare for that. And now I've got the added worry of, am I going to be exposed to this? And in the exposure, will I take it home to my family? So extrinsic cognitive load is just what the environment delivers to you. If there's chaos, if there's disorganization. I usually say that healthcare is by its very nature chaotic. It defines, you know, the chaos theory is a theory that even though everything is in motion and everything's moving all around it, there is a core thread of organization that runs through it. And so that is basically what healthcare is. It's a chaotic environment, but there is a core thread of organization that runs through it that allows us to function. Then the germane cognitive load is how I personally make sense and am able to blend both my extrinsic and intrinsic cognitive burden using my core capacities. You know, it might be that I'm someone who doesn't do really well at speed information processing. I'm someone who really has to have a lot of data points. So that can slow me down. It can add to my cognitive burden. So I look at ways, how can we alleviate that for the clinician, and how can we make it easier for them to carry that information that they need to carry? So you need to know that there are very distinct signs and symptoms of cognitive overload. Sometimes it gets mixed up, I would say, with burnout. My message to you is, if you're already at burnout, the cognitive burden has gone on too long, and it's added to and it's created the situation that you can find yourself in. But early signs of forgetfulness, errors of omission or commission, stress and sleep disturbance, anxiety and agitation, moodiness, irritability, or anger. I've had conversations with nurse executives who've said, you know, we're able to work with the nursing staff, and then suddenly we have folks that are just so angry and they make it difficult to work in their environment. And we had a conversation about, I would submit to you that it's not that they're just in general cranky people. There is a reason for that. There's a reason for when you have that nurse or those individuals in the work environment who just seem to bring a disruptive edge. If we can take the time and find out what is the load that they carry, what adds to that, and what do they bring to the environment that is so disruptive. They'll feel overwhelmed, loneliness, isolation, and then of course leading to depression and general unhappiness and complete and total burnout. We have to protect our teams and ensure that they can function in this highly variable and stressful environment. I think, as I said, the notion is that technology adds to cognitive load. It's something that everyone has to learn. It's something that they have to spend time working with and conforming to the way they like to use it, et cetera. But what we focused on, and I have spent many, many years interacting with nurses to understand, what do you need in technology, and how can we use technology to reduce the wear and tear on clinicians? And one of the first things that we can do with technology is allow it to carry the burden of memory. I'll just use the simple example of your smartphone. All of you listening to me right now have a smartphone. All of you rely on it to provide reminders or notifications of information that you have to have. There's many examples with it, but say I've made an appointment with a new physician that I'm going to see, but I know in general where their office is, but I don't need to know that information. I don't have to carry that information right now. The message is residing in my phone. So the day of my appointment, I get in my car, I plug my car into Apple Play, and I tap the message, and my car maps it and talks me directly to the front door of where I have to go. That's where technology carries the burden of memory. It carries the burden of information. And so what we've tried to do, or what we do with our technology, is create that simple one step, one tap, where the information that a nurse needs or a physician needs, anyone working with patients in that moment, then can be translated and carried and given back. I don't have to memorize lab values. I can just tap on a phone and that lab value is available to me. I don't have to memorize emergency call numbers. I can simply tap a button on a wearable badge and I can call for all the help I need in the moment that I need it. We do believe that you have to keep essential information with the clinician. One of my favorite sayings is just because you can doesn't mean you should. And I think when it comes to technology, it's easy to go into overload because it's easy to send information via a technical route. But what's very important in this cognitive environment that nurses constantly work in is that you keep essential information with the clinician. If they cannot act on it right now, it can wait for them in the EHR or at the desk. I would submit that only urgent lab values need to go to the nurse on any mobile device because the next thing you know, you create a cognitive load of information just flying to the phone and they're constantly having to deal with it, which leads to deliver actionable information only and only to the right person. We love our CC button in this technology world we live in, and it's not always necessary, which is why what we've done at Vocera is that you can send it to a message to multiple people, but if you send it to the person who is managing the information and they are busy, they don't even have to take action to do anything with the message. The message, if they refuse to read it, it will just go immediately to their head nurse, their charge nurse, or go to their unit manager or director. So the information never goes to a black hole. Those are other ways that we're able to carry the burden of memory to find essential information and then deliver that information in an actionable way. So we carry the cognitive burden. The technology, the software carries the cognitive burden. And of course, always provide information in a contextual, patient-centered way. It doesn't do us a whole lot of good to send a random lab value or a random medication notification. It always has to be in the context of the patient. And so we provide the ability for the nurse to keep all information, all conversations, everything related to the care of that patient in the context of that individual patient. So everyone has a record of the urgent conversation. You'll hear me say again in just a few minutes, talking about the difference between documentation and communication. Our EHRs are a reservoir of documentation, which, obviously we all have to do. But when we talk about working in the moment, working with our patients in the moment, whether we're dealing with pagers or phones or urgent communication of any kind, then that's information that cannot wait. And it's information that has to go to the individual wherever they are. There is absolutely nothing that's mobile about any device at all, except the user. And so we want to keep the user mobile. And to do that, you have to send information to them. So I just want to give you a couple of examples of what I'm talking about. When Vocera has worked with clinicians all over the world to receive feedback and understand how can we reduce this cognitive load? How can we help and assist clinicians to work in the moment, to have the information they need, when they need it, that it shows up immediately and they can act on it. So this is a picture of a nurse using the Vocera Smart Badge, which you can actually talk and text on, all hands-free. It can be worn under PPE. Nurses don't have to touch anything. I've seen so many pictures and talked to so many nurses who are, you'll see them standing around with a phone to their head, and it makes me cringe a little bit because here we are in PPE and the ED, but we're still holding a phone to our face. And we want to make sure that nurses don't have to do that they can communicate whenever they need to, and remain safe with their gloves away from their face, with their gown intact, their mask intact, and their goggles intact. So working memory is the ability to remember instruction or keep information in your mind long enough to complete a task. A simple example is just searching for data when you're trying to update a clinical document or a policy or procedure, and having to reference back and forth between the reference in the working document. How many times do you have to do that? Because you've got so many things going on that you cannot hold the information in your brain. You just have to keep toggling back and forth. You have to be able to capture and understand what the information is, put it in context on the document, And as tasks change and information moves in a very high stress, fast-paced environment, multiple demands are placed on a working memory. It becomes taxed beyond its capacity to remember changed values or discrete data points. It's in this space of burdened memory and forgotten tasks that mistakes are often made. Vocera technology can help carry that burden of memory by providing accurate, timely information to relieve the clinician's cognitive load. I'm just going to give you a quick little example with my little stick people. I presented to the American Organization of Nurse Leaders, and one of the comments I got was, "I love your stick people," because it helped her to really understand how this works. But here's an example of cognitive overload on working memory. Karen is a nurse on med-surg, and she's covering for her coworker Carl while he is on break. She listens to a brief report about his patients. She jots down some notes. She'll need to turn one of Carl's patients in about 20 minutes because he's an elderly man with pressure ulcers. So while Carl is on break, one of his patients, see, she's trying to commit it to memory, turn the patient, turn the patient. While Carl's on break, another one of his patients calls for pain meds. Karen checks the EHR to see if it's time for medication, what time the medication is due. And as she walks away, she leaves her notepad at the nurse's station. And by the time she remembers to turn the elderly patient, Carl is back, and it's been 45 minutes. What this does is it creates an issue of trust between Karen and Carl. He's thinking, I'll never trust her to take care of my patients. The patient is compromised. It creates issues all around. Just because Karen is so overloaded, she was unable to commit to memory and lost track of time. So with Vocera, the workflow is simplified. Karen listens to the report. She signs in to Carl's patients on Vocera so she can get all notifications and calls and reminders sent to her regarding his patients. She records a reminder to herself and says simply, turn Mr. Jones in 20 minutes. So in 20 minutes, her Vocera badge alerts and tells her to turn Mr. Jones. She is able to deliver the pain medications and receive information on her badge that gives her the diagnosis, meds, dose, and the pain score. So she doesn't have to go back to the desk. She's not at risk for not remembering, and the information that she needs in the moment comes to her in the moment. So that's how we can simplify using technology and look for ways to simplify the experience of the nurse managing. I'll give you just one other example on pattern recognition. Initially with COVID, the symptoms we thought we would see were cough, fever, and shortness of breath. Then suddenly patients started presenting with chest pain, inability to taste or smell, gastrointestinal distress, headaches, and low-grade fevers. And then recently we've been seeing more and more symptoms in different ways that COVID is presenting. I have a friend who's an ER physician in Austin, where I live, and he said that he had a patient show up with a toothache. That was his sole presenting complaint, was a toothache. But he said there was something about the patient that was off. He was afebrile, but he was just not feeling well. So he said, I've reached the point where I just test everyone. The patient was positive for COVID. Within a few hours was admitted to the ICU and actually ended up on a ventilator. And his sole presenting symptom when he showed up at the ER was a toothache. So we're just seeing some very random and odd symptoms that present to us. So when we look at pattern recognition, especially in something that is unpredictable as COVID, you start looking for things, where did I see that before? Or who had that? Or your mind starts to try to match up information, discrete information that you're holding in your memory with what you're seeing before you. Another example of that is when you watch a movie and you see an actor and you're thinking, now where did I see them before? You know, he didn't have a beard, but where did I see him before? And that is really pattern recognition, where you're trying to constantly match up. And you can probably think of many different ways you do that throughout the day. When you meet someone, you think, I think I've met you before. You're trying desperately to bring up the information that you need to match up what you're seeing with what you stored. So this is how Vocera can help clinicians with that particular phenomena. Here, Nancy is a nurse on a med-surg unit who's had Mrs. Jones, an 85-year-old patient with congestive heart failure for 2 days or 2 shifts. Nancy also has 4 other patients. But yesterday, Mrs. Jones was talkative. Today, Nancy hasn't had a lot of time to spend in the room, but she notes that Mrs. Jones is sleeping a lot. She didn't really recall what day it was. She had also sent a complete blood count and urine sample for testing from Mrs. Jones' catheter as it looked cloudy. And she got a message from the unit clerk that the lab called for her patient. And so she's very worried about this patient. And so she wanted to know what were the vital signs recorded. She noted that her blood pressure was lower, her pulse was slightly elevated. So she makes a mental note to check on her more frequently and asks the unit clerk to see if she can get the urinalysis results from the lab. Unfortunately, in an hour, Mrs. Jones is unresponsive and she's septic. And we all know what sepsis does to our patients. So this is how we manage that information with Vocera. Nancy is taking care of Mrs. Jones for the 2nd day in a row. She gets a critical lab result on Vena on her smartphone app that indicates Mrs. Jones has developed a urinary tract infection. As the CNAs or the nurse assistants do vital signs and enter them into Epic, a sepsis alert is sent to Nancy, the charge nurse, and the rapid response team through a clinical notification and integration with a sepsis monitoring system, coordinating between Epic and Vocera, and the system are connected several key indicators of sepsis to allow early detection and treatment. We have many hospitals across the United States who have set up alerts just based on a lab value. They are able to go in and just if there's a single lab value that is abnormal, it will send off an alert via Vocera to the nurse to take a look at the patient's entire picture, the vital signs, the lab values, and the status of the patient to determine if they need to be put on a sepsis protocol. So cognitive science provides a foundation for devising a strategy to help build nurses' resiliency. It helps us understand how we can support nurses by providing technology that consolidates information in the context of the patient and enables everyone to communicate the same way. And all of this to reduce the cognitive burden of the clinicians. I've provided a 3-point strategy on how these ideas can be applied, and I'll just quickly talk through them. Number 1, address the strategic delta between documentation and communication. I mentioned this earlier, but when caregivers are moving through a hospital trying to manage critically ill patients at warp speed frequently, and the patients just keep coming, information cannot be lodged at the workstation. Care teams are mobile, and information has to be kept mobile for them. Hospitals rely on the electronic health records as a repository of information. If information remains in that repository outside the context cognitive science provides, nurses can become confused, mistakes can be made, and over time, this heightened stress, it reduces their ability to remember, it reduces their ability to function in the moment, and then begins to work on their resiliency, which can lead to burnout. Another point of cognitive burden is causing the nurse to have to multitask and carry information in order to communicate it. Documentation and communication are essential. One doesn't work without the other. Yet today, as we said, no single platform can address both. So that's why I strongly suggest that you have a documentation strategy, which I'm sure that all of you do, but you also need a communication strategy that can work together with your documentation strategy to both relieve the cognitive burden of clinicians and improve the experience for everyone caring for the patient. Number two, give clinicians control over how they communicate. The COVID-19 crisis has made it clear that hospitals need to empower nurses to control the way they communicate. Let's say a nurse receives a patient who's been admitted through the ED. That patient's presenting with shortness of breath, low-grade fever, and headache. The nurse is thinking he needs to be tested for the virus, but I'm not really sure, and I don't know whom to notify. Should I notify the infection team? Should I notify the physician in the ED? We have to remove this burden of constantly having to adapt to varied preferences. I will go into hospitals to visit and have conversations, and not only does an individual hospital have a culture of communication, individual units will have a subculture of communication. You can go into the ED and they'll say, well, this is how we do it. You go into the ICU and they'll say, well, this is how we do it. And then you go out to the medical floor and it's, well, this is how we notify. No nurse should have to ask, does this doctor want to be paged? Does the other one want me to go through an answering service? How do I call the department I need to reach? You need to put everybody, nurses, physicians, ancillary staff, everyone on the same communication platform. Whether they communicate by texting or they communicate by calling, everyone needs to be using the same software so they can all function in the same environment. There's no question about how do I communicate. There's no question about where is the number. There's no one running to find the call sheet to get the numbers in. Frequently, we don't like to use more than one call sheet or more than one call software because we don't want any questions to arise. We don't want one to get corrected and the other one not. But select a communication platform that can work for everybody and drive usage behavior. Nurses and physicians communicate differently, and that's fine. They can use the same software, and they can use the same nomenclature, the same abbreviations, the same email format, the same framework. So nurses don't have to work in and out of systems. We would never, ever consider allowing folks to have multiple ways to communicate via email. They're all on one platform. and for obvious reasons, I don't need to enumerate them, but yet we allow people to use preferences of how they verbally and urgently communicate for the care of a patient. Number three, use software to enhance workflow, not detract from it. Clinicians need clear, contextual, just-in-time information. There's no time to be searching or struggling to communicate. It has to be pushed to the healthcare team on the go. It must be coordinated at the same time and in the same way. If alert and alarm notifications are not actionable, they don't need to go to the nurse. In other words, don't send information from a cardiac monitor that the nurse can't act on. Only send information that urgently needs to be acted upon. I've listened in on conversations between nurse executives who during patient surges are changing and easing documentation requirements. Many have realized we've overdone the documentation requirements. And now working through COVID, I was talking with some nurses in New York City who said, we just realized that we don't need all of this. We can consolidate and we can make it easier. So the patients were well cared for without X, Y, and Z document. So we just eliminated it now. And it's really given us an opportunity to say, let's just retool. Let's redo it a different way. One of the ways that we help is a group of clinicians work in our hospitals. These clinicians are executive level nurses who come in and they look at assessments and they interview physicians and nurses and understand clinical practice. And then we look at workflows to say, does this actually support the workflow or does this not? How can we fix what's broken and shore up areas of weakness? We need to understand how technologies and appliances work together. Applications are in their best when they can work with other systems like the EHR. So if there's a mechanism by which critical information such as lab values, vital signs, and sepsis risk is pushed out from the EHR, that is the communication path. That's how we go. So looking forward, I would say we're still sorting through the lessons to be learned. No one has all the answers. I wish we did. What we know for sure is that we are forever changed by what we are experiencing right now. We're, in the United States, we're going through another surge. We can't always control what happens, but we certainly can control our response and preparedness. Now is the time to make plans for all healthcare team members to have the tools that they need. How do we ensure we don't run out of supplies or unintentionally spread infectious diseases? How do we ensure that communication, which is the very backbone of patient care, is no longer just do it however you want to and let's figure it out, but it becomes really the thread through which all operational and clinical acts are centered around. Because when communication is clarified, when communication is consistent, then you reduce errors, you reduce burden, you reduce the cognitive load on everyone caring for the patient. One thing that I would point out is when we look at these devices that need to be cleaned between every patient and the PPE changes, how do we reduce that burden of thinking, did I do that? Did I clean? Did I take off my PPE appropriately? Did I manage? When we can just put a hands-free wearable under the gown and the nurse can function from that moment on. Some of you may be seeing a break or a slowing in patients showing up with particularly COVID. But then for many, the financial worries or the staffing worries have begun because we don't know what the future holds. I've had multiple clinical executives say to me, I have nurses who are close to the retirement age and they've just said, I'm not coming back for a second round. This has been so stressful. It's been changing. We have a document that we are looking at called Wiki Wisdom, where nurses are saying, I feel like I'm standing at the ocean with a Dixie cup in my hand, but I've never been more proud to be a nurse and see what we bring to the table. What we can do is define what is essential, ease the burden when we can, and use the lessons learned to plan for future crises that impact and strain our healthcare systems. At Vocera, we're here to help. I want to hear from you, and I want to see how we can further this conversation of using any policy, process, or tools that we have available to us to ease the burden and ease the cognitive load for those who are doing this very important job and really are our last line of defense in taking care of all of us. Thank you.
Thank you, Rhonda. That was fascinating, actually. Clearly, this is an area that you have a lot of expertise in. I just want to, if I can, pull together some of the comments you were made, but put it in the form of questions, just so you can walk us through some of the salient points, just to keep our minds focused. So this issue of cognitive load and cognitive overload, how do they differ? Or like, how does cognitive overload differ from that acceptable or normal or good load that you initially talked about?
Right. So, basically, cognitive load is the used amount of working memory resources. I mean, that's basically what it is. It's like, how can we manage the information that we're having to work with right now? You and I are experiencing cognitive burden because we're trying to be coherent and present information in a timely way. Cognitive overload is when unnecessary or unpredicted demands are placed on the working memory. The best example of that is in the hospital. I absolutely cannot predict what's going to happen with my patient, what's going to happen with the family, how I'm going to be communicated with. I always say, nurses, I've never had anyone ask me, how do I want to be contacted? I just got contacted, and I had to deal with it when I was working at the bedside. I just had to respond to whatever came my way. I can't control the amount of information that comes to me. I can't control how it comes to me. and I can't control the context in which it comes to me. So I am now left with the cognitive burden of sorting all of that information and accommodating all of the preferences of my environment.
Okay, and then we have these high volume events, these surge events like the pandemic, when we never know what's going to happen on a day-to-day basis, and we never certainly know what's going to happen in the next week. And you talked about those having an effect on the safety of patients, but also on the well-being of nurses and frontline workers. How does that come together?
Yeah, I think that's the hardest thing for executives and leaders to look at, to just say, you know, we have a patient population that we have to take care of, and we have staff that need to take care of them. So, and I've actually had nurses say to me, I appreciate the pizzas and I appreciate the muffins and I appreciate the healthcare heroes and all of that sort of thing. But really what I want from you is to understand that I'm mentally and physically and emotionally exhausted. And I need to be able to come to work and understand that I have all the tools I need, I have all the supplies I need, and I'm working in an environment that has an organization to it that understands my personal needs. And so I think that the hardest thing to do is to ensure that everyone feels like that they are being heard. I do think that that's actually quite difficult, because obviously this conversation that we've had is that everybody hears and responds in a different way based on their own personal cognitive burden at the time. But I just think when cognitive load or fatigue goes unresolved, it leads to compassion fatigue, it leads to burnout, and eventually it leads to mistakes or gross errors that are very difficult to manage, and then can be lifelong for the caregiver and the patient and the family.
Okay, so those are the things we're hearing from the front line. But what about the healthcare leaders? A lot of the people in our audience today, what are you hearing from them about their needs?
Yeah, that's a great question, Nancy. I think that one thing that we've seen is the improved communication between nurse leaders to be able to coordinate. I'll give you an example. When New York was surging so badly, I was on a call with 4 nurse executives who were working diligently to figure out, what do we do? Why do we all need to replicate what we're experiencing? And what they decided to do was work together to send the well patients upstate to hospitals in upstate New York, and a hospital on Long Island then was just turned into, basically it was about 90% COVID patients. So they were able to rotate the clinical staff in and out of what they called the COVID hospital. So they would not have to work long days on end. They could rotate in and out of that very stressful environment and then move into a less stressful environment. I think that the teamwork and looking at how do we ensure that they have the supplies that they need. PPE has and continues to be an issue, and how do we manage to conserve what we have? How do we manage to utilize what we need?
Okay, so I'm going to switch gears a little bit here. And we often think about these clinical communication tools as essential to our practice. But you also talked a bit about, and I want you just to say a little bit more about, considering these communication tools as part of our PPE. How does that fit?
Yes. You know, when I look at PPE as essential, the other thing that I have to have that's essential to care for a patient is communication. I can't do it alone. None of us listening in can do it alone. It requires teams, and to coordinate teams, it requires communication. So if you want to keep your patients safe, you want to keep your employees safe, what you need to do is to provide them communication tools that the software then can define the conversation. I don't have to carry a call list. I can say, call cardiologist on call if I don't know his or her name, and the software will find who's on call. I can say, call respiratory therapist on call. The software will find who's on call for the day. All of those things, the software is what is the most robust, I would say, behind the Vocera technology. The ability to call for teams, to be able to say, I need a lift team, or notify the wound team that I have a patient. I don't really need to know who's working on the wound team that day. I just need to know that when I call, everybody who's on that team will respond. And one thing that we do that is so important for folks working today with, families being separated from their loved ones in the hospital, it really has created a crisis of anger and aggression towards some healthcare workers, especially in the ED. To be able to, even though when I'm covered in PPE, when I should not be putting my hands anywhere near my face or my body because they've been contaminated and I've got an issue, situation going on, I can just say, okay, Vocera, call security team, and they will get the message immediately, all hands free. And that is what we work toward with the badges. And you can see Gracie, this is Gracie. She's one of our spirit animals here with wearing her Vocera badge. And she was able to communicate directly from the parking lot while she was triaging COVID patients into the hospital, and her colleagues were in PPE with the badge underneath the PPE, and they were able to communicate without ever having to break protocol or break the coverage.
Sounds really good. I'm really conscious of the time. We've got about 10 minutes left on this webinar. And what I'd like to do right now is call on Brenda Lamy, and she's been monitoring our participants and our audience and their questions. So Brenda, can you give us a few of those pertinent questions and those issues?
Yeah, thank you, Nancy. And for those of you in the audience who want to submit a question or wondering about something, the Q&A icon at the bottom of your screen is where you can put those questions in, and I'll be sure to moderate those. We do have a couple of questions for you, Rhonda. One is, what are the ways leadership can ease the transition to the use of technology when the cognitive load at baseline is already high, especially those who are not technically inclined and or resistant to change?
That is a great question, and it's one that I get frequently. So you have to allow time for training. Number one, I think sometimes with simple things like phones, everyone's like, well, everybody has a phone. Not everybody uses it in the same way. My 83-year-old mother has a smartphone, but she uses it very differently than how I use it. Her comfort level with it is very different. So always assume that you're working from a baseline of no one knows anything. The other thing that I have seen work very effectively is pairing up a younger, more technology savvy nurse with an older, less technology comfortable nurse, and allowing them to be partners so they can ask the questions. They can learn in privacy outside the classroom, so there won't be embarrassment or reluctance to use. I think part of teaching on technology is starting small. We frequently want to do the big bang, where it's like, well, we're just going to push all this out and everybody's going to start using it tomorrow. And I think that many of us have discovered that's not the way it works. I think what you do is you start small. If I was telling someone today on Vocera, you pick the top 5 communication issues you're trying to resolve. Is it emergency response? Is it managing your call teams? Is it, nurses communicating with patients? And you solve those. And then you continue to build and grow. I think that one of the things that, one of the errors that leaders make with technology is just assuming we're going to give it to you and then you'll use it forever and always and it will be the same. Technology is a living, breathing entity. For it to treat you right, you have to treat it right. And it is only able to give you information if you give it the intelligence to do that. And so your intelligence is what customizes it to you. It's the same thing when you get home with either your new phone or your new iPad and you start putting in all your preferences. You have to understand that clinicians are going to have preferences on how they manage their technologies. And I would suggest that you allow that, that they need to be able to use it in a way that makes sense to them and in the context of their work. I know this is a long answer, but I want to say one more thing. When I did my research on for my doctorate, I was looking at nurses' acceptance of just using text messaging for patient care. And one of the things that I discovered, it had nothing to do with how many steps it takes. It had nothing to do with how many applications. It had everything to do. In fact, they scored statistically so low, they were not even relevant, those 2 items. What scored the highest statistically was context. Does it fit within the context of my work? Does it enhance my work or make it harder? And healthcare is unique in that when it doesn't fit within the context, they are very quick to abandon the solution, as many of you listening know. Very quick to abandon. So the acceptance margin in healthcare is very, very narrow. And so that's why a lot of time has to go into preparing and understanding exactly what it's going to be used for and how the clinicians expect it to deliver for them.
Great, thank you. So many great points in there. We have another question here. Where have you seen best practice in nurses being able to input design influence how they communicate, are communicated with, and what does that look like?
Yeah, a great question. It's kind of a follow-up on what I was just talking about. Frequently, I will say this, nurse leaders frequently surrender the technology conversation to the gearheads in the room or the technology experts in the room. And I'm going to look you straight and say, don't do that. When you surrender your power, just because you don't understand the words, you don't understand the conversation, it makes you uncomfortable, it's not your expertise. I strongly recommend that you remain in the room and you sit at the table, because the technology experts are not clinicians. They don't understand clinical practice. They don't understand how this has to work in the environment. So I've had so many conversations with technology experts in hospitals who say, but I use it this way, and this is how I use it. And I'll smile and say, as a clinician, I would never use it like that. It's not reasonable. So we need to always have this partnered conversation. It's why the role of the Chief Nursing Informatics Officer has become so prevalent in certain areas, because you have to have someone who sits in that delta between clinical practice, technology expertise, and technology ease. But I say the CNIOs are usually the ones who determine, does this thing work in our clinical environments here? Will it sit on our technical platform, and will it enhance the clinical practice? And you have to commit to that expertise. You really do, because we're all moving digital. We all are. I mean, it's not something you can escape. I always say the train's left the station on that. It's happening. So do the right thing in preparing to have the experts. If you, as the chief nursing officer or the nurse executive for the hospital or the system, are really uncomfortable with that conversation, find someone who can advise you. But ensure always that they have the perspective of the clinician at the bedside.
Okay, thank you. Nancy, just turning it over to you for any thoughts.
Well, I don't have a lot of thoughts except to say this has been amazing. I want to say thank you to Vocera for sponsoring this webinar, because that's a big commitment, but also to you personally, Rhonda, for putting together this presentation and for fielding the questions. It's always hard to be put on the spot when you don't know what's coming at you.
Yeah.
So again, thank you very much for that. Being very, very conscious of the time and making sure people get out of here for their next meeting, which always happens. I also want to just say thanks to my colleagues at the Canadian College of Health Leaders for organizing and hosting this webinar. And I understand that it will be going into the CCHL library for members of CCHL. So participants, thank you for joining us today. This has been helpful, and to me, I hope it's been helpful to you. And let's all stay well out there.
Thank you so much. Thanks, Nancy. Thank you, Brenda.
Take care.
Thank you.
Good afternoon.